I'm an interventional radiologist, as you told before, and you told me to speak about vertebroplasty without no time limits, but don't worry about that. I try to not bore you for all the afternoon. By the way, here are my disclosures, and here are the learning objectives I passed and copied on my slide. The learning objectives I received just yesterday. I try to treat each of one, not in the same order, but I try to answer to all these questions. Now, what are the options we have today for treating vertebral fracture? Starting from conservative, bed rest, corset brace, and or traction, mini-invasive, vertebroplasty, kyphoplasty, and intravertebral implant, and surgery, posterior, anterior, and combined stabilization. Since I'm an interventional radiology, I will speak about less invasive technique. That is the focus of my talk. We know that vertebroplasty is a mini-invasive procedure where the bone cement is injected inside a fractured vertebral body to treat pain associated with the fracture, and consists of the injection of the bone cement inside the vertebral body through a needle positioned under CT or fluoroscopy guidance. The cement functions as an internal cast in the vertebral body to provide pain relief and stabilization at the same time. If you are beginners, main terms are accurate selection of patient, adequate technological support, good choice of material, as well-trained operator dedicated to keep high-quality fluoroscopy and multidisciplinary team. Many scientific societies wrote the guidelines for vertebroplasty. Nowadays, we know that we can perform vertebroplasty when we have osteoporotic, traumatic, malignant, or painful angioma fracture. We could perform this procedure under day-case surgery and local anesthesia. And we can choose or a CR, but remain high-quality CR, or combined CT and fluoro guidance, or if we are rich, 3D rotational angiography with combined CT. The procedure is performed under local anesthesia or deep sedation. I do general anesthesia only if I treat cervical spine with transolar approach. And if we know the radiological scale, we have to put the parallel plates and the pellicle and the spinous process exactly in the middle is the only way to prevent complication due to the positioning of the needle. This is the summary of the steps. Be careful if you are a beginner, stay in the ring until the needle has passed the posterior vertebral wall. In order to avoid complication like that, spinal cord direct lesion followed by canal leak due to wrong positioning of the needle. Here an example of a vertebroplasty. Our 8-year-old male was a T7 traumatic fracture. We introduced the needle. Here the combined CT reconstruction, extracting the needle, and when we are extracting the needle, we inject the bone cement to have a perfect feeling of the vertebral body with the good spreading of the bone cement. Vertebral plana was a contraindication in the past. Now we know not only that we can inject 1 cc of bone cement to have complete relief of the pain, but also sometimes we can also put some implant like the spine jack, for example. Here an example of T3 hemangioma. We have to have the cooperation of the neurosurgeon to have a surgical standby in that case, because we could have any complication, but that case was perfectly solved with injection of the bone cement inside the vertebral body, and also with the reduction of the epidural mass as well. Another another particular case is the combination with the posterior instrumentation when we have the patient still on pain after the posterior instrumentation. We can introduce two needles, inject some amount of bone cement to have complete relief of the pain. One of the questions you asked me, is possible to treat multi-level patient? It's possible, but you have to take care and don't inject more than 20 cc of bone cement for all the vertebral body, as the US guidelines say, since we could have fat pulmonary embolism due to the dislocation of the fat inside the vertebral body. So if you put 7-8 cc of bone cement for each vertebral body, you couldn't perform more than 3 levels. And one other question you asked me is how to prevent leakage. The only way to prevent leakage is to inject the bone cement under continuous fluoroscopic guidance. No other way to prevent leakage, because if you see continuously where the cement is going, you could prevent leakage stopping injection of the bone cement if you see a leakage going posteriorly in the spinal canal. Of course, if we have distal leakage or venous leakage, I'm not worried about that, because also a venous leakage close to the nerve root, we can solve it but with an injection of steroids or ozone. If you don't care about a huge venous leakage, you could have also a pulmonary embolism, but check in your fluoroscopic guidance where the bone cement is going. If you see that you are feeling some venous drainage close to the vertebral body, probably that bone cement could go into the pulmonary circulation. So you have to stop in order to avoid or fatal pulmonary embolism or cardiac perforation due to some stakes of sticks of bone cement coming from the vascular leakage as well. Cervical approach is completely different because it's anterior approach. This is a metastatic lesion of C7 with anterior approach. It's possible to fill the lesion and to obtain the pain relief of the patient. Another example, 1-3 multiple myeloma involvement. The patient was prescribed to put the halo jacket. She obviously refused, and we was under general anesthesia with transoral approach. We completely filled the lesion in C1 and C3, solving the problem to that patient, and she is grateful for all lifetime. And this is a really interesting paper because after the vapor, they underlined the amount of potential risks of vertebroplasty compared to the complication if you don't perform the vertebroplasty or the kyphoplasty. I mean, okay, we leave the patient with corset brace without any treatment, or with the osteoporotic treatment with the systemic treatment. Okay, we can have a cardiovascular and pulmonary disease, pulmonary complication that leads to an increasing of the mortality of this kind of patient with vertebral fracture. So be careful that you can have complication if you do the procedure, but you can have much more complication if you don't do the procedure. And if we consider that this is a new way to consider a vertebral fracture as a fracture of another joint, the knee, for example. And why don't apply the AO principle to reduce the fracture, to restore anatomical relationship? Fracture fixation, providing absolute or relative stability as the personality of fracture, patient, and injury requires. Preservation of blood supply to soft tissues and bone, early and site mobilization of the injured part and the patient. we know that balloon kyphoplasty is the inflection of the balloon before injecting the bone cement to have high restoration, like in that case when balloon kyphoplasty. Same indication of vertebroplasty, but reduction of local kyphotic angle more than 15 degrees, especially if we have a fracture into the thoracolumbar junction. Another device similar to the vertebroplasty is the Tectona system. The difference compared to vertebroplasty is that vertebroplasty inflate the balloon 360 degrees. With the Tectona system, it's a lamellized direction nithinol strip that provide bone remodeling in the direction we want. So not the entire vertebral body, but only where we want to get the high restoration. And after that, we can inject the bone cement by means of dedicated bone fillers. This is an example CT before and after with good fitting of the vertebral body and reduction of the fracture. And even if there are few studies in literature, the study we done was provide encouraging results for this kind of device. And the indication for vertebroplasty, kyphoplasty, and implant was assessed by this multidisciplinary international staff applying the UCLA method. And also implants demonstrated to be safe and effective not only in pain reduction, but also in reducing leakage, vascular and venous leakage, and also in providing long-term high restoration. And the use of the implant was put on the market just for reducing the secondary loss of vertebral body height encountered with kyphoplasty after balloon deflation until cementation. Remind the Verlan study 2005. One of that is the vertebral body stanting, is the balloon expandable stent that can be delivered inside the vertebral body after the inflection of the balloon, and then the bone cement could be injected with dedicated bone filler. And has been demonstrated safe and effective for traumatic patients. Not too much in osteoporotic patient, providing similar results to not better results compared to kyphoplasty. Good results in treating tumor patients. This one application combined with posterior screws purposed by the group of Alessandro Cianfoni. The Kiva is a PEEK polymer cage inserted through a nitinol coil inside the vertebral body. Especially useful in tumor because provide the containment of the bone cement, create a caging to inject the bone cement. But also, and this is another answer to your question, the cage has been demonstrated useful in treating A2 mager thoracic or lumbar fracture without any neurological deficit. The Kiva system also has been demonstrated safe and effective in the treatment of tumor lesions. The Vertebroplasty is a porous surgical mesh which allows the interdigitation of the bone cement within the bone trabeculum, and can be introduced with unilateral or bilateral approach, and then we can inject bone cement, and has been demonstrated useful in osteoporotic fracture or metastatic fracture. As well for the Soteira, also for spinoplasty, in reducing leakage and risk of leakage-related complications. The tripod is the newest one is the 3 lamella expansion, titanium made, provide hair restoration, especially in the anterior part of the vertebral body. Can be introduced by with bilateral approach, and after it's deploying, the bone cement can be injected. And we don't have any study about the clinical study about the tripod, but biomechanical studies since now provide its efficacy. The spine jack is different from the other because apply a cranial force opposite to that caused the fracture, reducing the fracture, preserving the trabecular structure, and maintain the restoration in long term. I show you some extreme case that the spine jack allows to do. Of course, not for beginners. If you have in your hand a spine jack, you should have an adequate learning curve. For example, this is a 57-year-old male, and this is the fracture we treated. 20 minutes, deep sedation, patient went to home in the afternoon, avoiding surgery and avoiding course of brace in that case was not indicated for sure. Another interesting case, this is a fracture with retropulsion of the posterior wall. Another answer to your questions. The spine jack, since it applies a cranial force, provide ligamentotaxis, and after that procedure, we have the complete reduction of the retropulsion of the posterior wall as assessed by the CT. In that case, since the patient was osteoporotic and since we had a loss of the kyphotic angle, was better to, according to American Journal of Osteoporosis guidelines that indicated the risk of fracture, we do prophylactic vertebroplasty in adjacent levels. Another fracture, A2 fracture. Another answer to your question. The patient has 2 vertebral body. For the upper level, vertebroplasty was enough. For the lower level, we did the spine jack, having the reduction of the fracture. And many studies provided the efficacy of the spine jack also in preventing the degeneration of the intervertebral disc. Did a study compare the spine jack with the VBS, with the balloon kyphoplasty, with the osteophyx alpha-tech scientific spine, providing the best results. This other study, I guess all of you, everybody knows the SACOS study that compared the balloon kyphoplasty with the spine jack. 13 centers. I was the only Italian center, and we demonstrated that not only the non-inferiority of the spine jack compared to the kyphoplasty, but also the superiority in terms of pain relief, middle-high restoration at long-term follow-up. And the last issue also demonstrated the efficacy of the spine jack in the treatment of multiple myeloma. This is my personal VCF treatment, the spine jack for each kind of fracture. The other to evaluate on a case-to-case basis. So, do it, you have to use this kind of device, but not too much. First of all, because they are a wonderful device, but you have to go before an adequate learning curve. Moreover, be aware to the correct indications. Now, I'm sorry if I'm boring you, but I need 10 minutes more to discuss about the literature. Because we have the literature, we have the question we have now is vertebral augmentation safe and effective to reduce pain and disability for patients with fracture? And what is the best management of osteoporotic fracture between non-surgical management, vertebroplasty, and kyphoplasty, or implants? This is the first randomized trials published comparing vertebroplasty and conservative care. So optical medical treatment means systemic treatment for osteoporosis, and it provides better results for vertebroplasty. As well, this other study published on The Lancet, a trial where kyphoplasty was compared with conservative care 1 year follow-up. Better quality of life for kyphoplasty. Same results for this study, and faster recovery for vertebroplasty patients. Do you remember this guy? His name is David Kalmesh, neuroradiologist in United States. In 2008, he promoted the multi-level vertebroplasty. If one vertebroplasty is good, 2 must be better. So do vertebroplasty. 1 year after, David Kalmesh was published one of the 2 articles on New England Journal of Medicine. I couldn't understand why these 2 kind of articles has accepted for publication in such a high-level journal, because they have many bias. They mix apple with pear. They didn't do MRI in all the patient. Crossover was not allowed. So, and they injected the local anesthetic as a sham procedure inside the vertebral body. Doesn't matter if fresh or chronic fracture, because they didn't know. And nowadays we know that one of the problems of chronic fracture is the basivertebral nerve inflammation. And now we treat this kind of patient with a basivertebral nerve ablation. And everybody of us know that the small cement worked also in chronic fracture, providing a lysis of the basivertebral nerve. By the way, we have many commentary to that kind of articles. Abby, that's not stupid, assessed that that kind of papers was artificial content for desk writers, far away from clinical reality. No use for the patient or for the treating doctors. This is the long-term follow-up of the Kalmesh study, the INVEST, providing no statistically significant result for vertebroplasty. This is the Vertus 2. Vertus 2 compared not sham, but medical therapy, osteoporosis, drugs, providing better results for vertebroplasty. As well as that paper, optical medical therapy, sorry. Forgive me. Again, Kyphoplasty, conservative care. Kyphoplasty, better quality of life improvement. This is not a randomized study, it's not a trial, but is a huge number of patients treated. 4,547 patients, 13,000 level treated, 6 Italian centers, providing good results. This is a comparison between vertebroplasty and kyphoplasty, as you asked me. Similar results in terms of pain relief. Kyphoplasty more expensive, kyphoplasty more operation time, so more fluoroscopy, but less leakage rate and high restoration provided. All of us expected the Virtus 4, like Jesus Christ, but the Virtus 4 provided results not so many different from the two New England Journal of Medicine study. Even if they comment they didn't have a sham and statistically significant difference between sham and ball cement, but they assessed that we don't have the sham in our clinical practice because it's not allowed to inject vertebral anesthetic in our daily practice to treat a vertebral fracture. And if we want to use local anesthetic to treat a vertebral fracture, we should have approval of our ethical committee because it's not allowed. In our daily practice, we can compare conservative care and vertebroplasty, not sham. We don't have local anesthetic as in our possibility. Moreover, the bone cement provides a lower risk of vertebral fracture of adjacent level. For the first time, a paper assessed that the bone cement don't provoke adjacent fracture level, but reduce the percentage of adjacent fracture, of new fracture in adjacent level. Bill Clark designed a study comparing sham and vertebroplasty with a big difference. He treated acute fracture within 15 days, no more. And with the technical of maximum feeling. So for the first time, he promotes the feeling of the vertebral body from end plate to end plate. We know that 1 cc is enough to have the pain relief, but if you feel adequately the vertebral body, you could prevent further collapse. And this is the study dedicated to the adjacent vertebral fracture. Vertebroplasty protects again further vertebral fracture, as well to that paper published on Pain Physician. This is the Cochrane Library, but the Cochrane Library belongs to Rachel Buchbinder. So results are the same of New England Journal of Medicine. But be careful, they included only 8 randomized trials. Only 8, studies. No more. Only 8 studies. We have thousands of studies in the literature. Where is? Probably nobody knows that Kalmes and Rachel Bubinder are consultants for periparatitis. But this is my personal opinion. By the way, kyphoplasty is this is the summary of what I told you before in terms of longer operation time and incidence of adjacent level fracture. This is an interesting paper because after the two papers published in New England Journal of Medicine, they evaluated, I don't know what happened, they evaluated the mortality after 2009 in patients with vertebral fracture. And we have a huge increasing of mortality after we decrease the number of vertebroplasty procedure. So, two articles, New England Journal of Medicine, Vertos 4, and stop. We have many, many other trials, on the other hand, that provide efficacy to the vertebroplasty. And this is an interesting slide. This is the US registry, a snapshot of what happened in the reality. I don't want to bore you. I want to show you only the conclusion. This is a slide of my friend Doug Bill. I read for you. Vertebral fractures are very common and associated with high rate of morbidity and mortality that can be statistically significantly reduced with vertebral augmentation. Current literature overwhelmingly positive for vertebral augmentation, except for sham trials. The registry shows profound patient benefits in pain and function improvement and almost no complication. Shams that dock on bone and infiltrate anesthetic are not shams and create impossibly high benchmark to overcome because you couldn't consider sham something that leads to 5 points reduction in VAS score. We have 5 points reduction. It's crazy. Despite this real-world data shows kyphoplasty can produce profound improvement in pain and function. So, vertebral augmentation is one of the most effective techniques of anything we do, and may be the only thing that compares favorably the most stringent benchmark. Registry data is critical and at understanding the real-world outcomes of vertebral augmentation. This is the comment of my friend Doug. Another paper demonstrated the increasing of the mortality of 22%. This is the EVOLVE trial about kyphoplasty, producing huge positive results in terms of functions, SF36, Oswald Disability Index, VAS score. And what about implants? Implants has been demonstrated to have good efficacy as published in that review in terms of long-term high restoration. Most important is to have good patient selection, for vertebroplasty, kyphoplasty, and implants. And recent data indicate vertebroplasty results in early hospital discharge, lower readmission rate, and reduction of the mortality. This other study compare the vertebral augmentation is safe and effective low rates of serious complication, and no increase in subsequent post-treatment fracture risk. This is my last slide. After that review show, the title of this paper was Resurrection of Evidence of Vertebroplasty. This is a very nice painting from Tintoretto. It's called The Resurrection. And we really hope that is the resurrection for this technique. Everybody of us know that it's really helpful. Thank you very much. If someone is interested, we have in December in our hospital a live course, 3 days of each kind of interventional procedure, not only vertebral augmentation, but also disc decompression techniques, RF innervation, tumor ablation, spinal cord stimulator, microendoscopy, treatment of spinal stenosis with dynamic spacer or fusion spacer, screws for facet fixation, each kind of interventional procedure. Thank you very much again for your attention, and I'm available if someone has some questions.
Thank you so much for a wonderful presentation, a very informative and comprehensive lecture. We have several questions in the chat as well as some comments. So with your permission, I'm going to start with the first one. İzmir Online Neurosurgery, Dr. Professor Hasan Kamil Sucu wrote, I would like to thank Dr. Stefano Marcia for this excellent presentation. He gave very fascinating and satisfying information about not only vertebroplasty, but also almost all vertebral augmentation systems, many of which are not available in Turkey. Thank you, Professor Sucu, for your comment. And a female neurosurgeon from Turkey, Dr. Selin Bozdav wrote, thank you for this detailed presentation. We listened with pleasure and curiosity. I have a few questions. The first one, do you recommend vertebroplasty or kyphoplasty for type A1, A3, A4 fractures in junction areas like TH12 and L1? So this is first question. If you recommend vertebroplasty or kyphoplasty for type A3, A4 fractures in TH12 and L1?
Well, A3, I did for sure. A4 depends because it's less stable, and I'm not sure. Usually, I discuss with the spinal surgeon the case before, but for A3, I do.
There are publications recommending vertebroplasty for the treatment of persistent low back pain attributed to MODIC-1 changes. What do you think about this?
I think that in the past we didn't have. I answer to you with during my talk because MODIC change could be inflammation of the basivertebral nerve. Now we treat basivertebral nerve with a dedicated ablation system. We didn't have in the past a dedicated ablation system. So in the past, you know that you have some patient that usually they say, do me something, but give me the pain relief. And we try to do vertebroplasty in that kind of patient. It worked, and we did. Now, if I should have this kind of, when I have this kind of patient today, I will perform basivertebral ablation.
Thank you. Next question. Do you recommend vertebroplasty for pediatric patients like 12 to 16 years with acute thoracolumbar fractures?
This is a good question. We have depends on the type of fracture. First, because if we need hair restoration, because we need a spine jack, for example, I don't worry about the bone cement. But if we have only impact fracture, or in young patient, but not pediatric. In young patient, I can put some calcium sulfate or calcium phosphate, and we have the ceramic bone cement in the past, or the Cortos. I published something about that. Was better to use biological bone cement with new bone growth, and to avoid to use the PMMA, even if now it's been demonstrated, because the first vertebroplasty was done in 1987, so now it's been demonstrated that the bone cement is well tolerated also for so long time. So I don't worry as before, but if possible, I choose another kind of bone cement. But if I use a spine jack that has a titanium lamella, if I use an endoprothesis or an implant, I don't care about the PMMA.
Thank you for an honest response. Next question. What type of anesthesia do you use during procedure? I may have missed it. Do you use the erector spinae block? There are opinions that the erector spinae block in kyphoplasty increases the effectiveness in restoring the height of the vertebral body because it relaxes the muscles. Do you agree?
No, I use deep revamp propofol, deep sedation.
Okay.
For each kind of I use a fully local anesthesia for vertebroplasty, and I use lidocaine and ropivacaine under the periosteum. No other kind of local anesthesia, no other kind of anesthesia in simple vertebroplasty. For kyphoplasty, implants, and also for the other procedural space or something like that, I use deep sedation. That means deep revamp propofol.
Okay.
But depends on the anesthesiologist. Not depends on me.
That's also
I don't want general anesthesia. The only thing I ask, no general anesthesia. For the rest, do what you want, but and we have a good compromise. So.
Okay, I guess only for transoral approach, general anesthesia.
My transoral approach is necessary for other reasons.
Professor Suju is asking, does vertebroplasty increase the life expectancy in the patients with osteoporotic vertebral fractures?
There are more. I show you papers that confirm that.
Yeah, thank you. Dr. Juvait Temiz is asking, thank you for this interesting presentation. Also, I have some questions. If you like, what is your opinion about corpus mixed elastic modulus after vertebral kypho or vasoplasty procedures? What do you think about this hypothesis about adjacent segment degeneration or fractures due to this issue? If it is so, all mechanical toys like SJ useless. And the second, what is your opinion about BTCP or tricalcium phosphate kyphoplasty or vertebroplasty? These methods can be used acute non-osteoporotic traumatic fractures, especially in young population. The question sounds this way.
Okay, the silicone bone cement has been put on the market, but didn't show good results. But after the paper published by Vertospo, Firanescu, and the other papers on pain physician, I'm not worried about the adjacent level fracture. So personally, I have not the necessity to use the silicone in the vertebral body fracture, even if the few cases I did, I noted less effect in terms of pain on pain relief. Regarding the second question about the calcium phosphate cement, I already answered to you in last in last question. I used it. I believe in that, but taking account that for young patients have their indication for elder patient has no sense. Also because if you use calcium phosphate or sulfate in osteoporotic fracture, they are not useful because you need that the metabolism works well to have new body growth. If the patient is osteoporotic, the metabolism doesn't work good, so they couldn't have new body growth even after you stimulate that.
That makes a lot of sense. Next question from Turkish neurosurgeon Yan Kanat. Thank you for a good presentation. I want to ask whether bilateral vertebroplasty is superior to unilateral vertebroplasty in osteoporotic and non-osteoporotic compression fractures.
Bilateral, unilateral,
or unilateral. Which one is superior? Which one is better for?
Which one is better? Okay.
Yeah.
Personally, I do 99% unilateral for vertebroplasty. Unilateral. I do bilateral. I mean, I put one more needle, or during the procedure, if I don't have enough, if I don't have the spreading of the bone cement on the other side. So, okay, I need to feel completely the vertebral body, and then I put another needle. Or when I'm treating a tumor lesion, so I have to reach the lesion on different in different points, so I put two needles, but it's quite real.
Thank you. Dr. Ayan has another good question. So in all patients, pain usually subsides after vertebroplasty procedure. What is the mechanism of recovering of the patients from pain?
What is no problem, I don't understand you. Could you repeat?
Not easy to answer, I guess. Like, what is the mechanism of the pain subsiding after the vertebroplasty?
What's the mechanism of the pain? Pain
goes away.
Pain goes away. Okay.
Yeah.
Well, the mechanism is it's simple because the bone cement, the pain is due to fracture. First one is the trabecula of the vertebral body. They are not stable, like a building. And when you fix the trabecula, you stop the pain. Not only the cement provoke the lysis of the nerve inside the vertebral body, kills that. Yeah. Chemically and thermically. So this is the mechanism of action.
Thank you. Next question from Ismail Bozkurt. Sincere gratitude for your comprehensive presentation. Do you perform any sort of curettage or suction for lighting vertebral body lesions before augmentation?
I do the curettage only in case of tumors.
Okay. Next question.
Or sometimes with the new tripod, now I think about that, the new tripod has in that system the drilling system with the curette.
Okay.
Oh, unless you're meaning the drilling system is provided in spine jack, in the DBS, in all the implants. So if you consider the drilling a curettage, I do. If not considered drilling a curettage, I don't do unless in few cases.
Okay. A young neurosurgeon who specializes in spine from Bulgaria, Edwin Vasfi, is asking, do you recommend using vertebroplasty in the body of the vertebra if the patient has spondylodiscitis? Do you recommend injecting bone cement inside the intervertebral disc in the patient with spondylodiscitis?
Absolutely not.
Not.
Spondylodiscitis is one of the first contraindication for vertebroplasty. Yeah. In the past, some bone cement with antibiotics were purposed, but personally, I never use that.
Professor Dr. Mehmed Nur is asking, I greatly appreciate your talk. Do you think osteoblastic metastasis to the spine have indication for augmentation? Metastasis to the spine.
Indication for augmentation are provided by NCCN guidelines at first, and the Wallace algorithm. So if you have, but they don't differentiate among osteoblastic and osteolytic. So first, when we assess the indication for that kind of metastasis, now we can think about osteoblastic or osteolytic. Personally, I try to do radiofrequency before each kind of augmentation, because I strongly believe that radiofrequency provide a debulking of the tumors and kills the tumor cells also in the border of the lesion, and allows better introduction of the bone cement. So personal use, I'm so sorry, I didn't think you were interested in tumor, so I didn't include the tumor ablation system slides in that presentation, but personally use the different tumor ablation system for that.
Maybe for the next time, Professor Sergio, we can invite Professor Marcia with a new talk, because the audience is very keen and eager. That we have a lot of questions, and we have a lot of thanks. I see Kenny Rojas.
If you want, we can arrange another presentation with tumor ablation, or
yeah, that would be great.
Or spacer if you want. But I'm sure that I speak about spacer. We could have many discussions.
Yeah. We have many thanks from Guatemala. Kenny Rojas is saying excellent presentation. Thank you from Guatemala. We have thanks from Ukraine. Ukrainian neurosurgeon Andrei Netlyuk is writing, thank you for the interesting presentation and comprehensive information. Barish Saigili, thank you for the exciting presentation.
Barish Saigili is from Albania, and is Turkish, but is working in Albania. Yeah.
Albania. Neurosurgical resident Dr. Nurullah Kosman is writing, thank you, Professor. It was a great lecture from İzmir, Turkey. And we have another thanks. Thank you very much. Do you optimistic about to find more physiologic material instead of PMMA? So I guess this is the last question. More physiologic material instead of PMMA.
More physiologic material, the bone cement we talked before. Calcium sulfate, calcium phosphate, the Cortos was an acrylic resin.
Thank you so much. You answered all my questions through the course of the presentation. Thank you very much. And I don't see any questions in the chat. I would like to thank you again, once again. Dr. Suju, do you have any comments?
No, I wrote already. I want to thank again Dr. Marcia and for this excellent presentation. And I want to thank everyone who joined us, who joined the meeting, and making comments, asking questions. And I thank everyone. So I hope to see Dr. Stefano Marcia in real life in Turkey or in Italy someday. Thank you.
Thank you. Thanks to you, and keep in touch.
Yeah, we will.
Next time.
We will.
It's a really pleasure, because also I have a good feeling with Turkey. When I visit Turkey for the first time, my guide, I have a nice lady as a guidance, and she belongs to Sufi they are the mystics of the Islam.
Okay.
And we discussed of many things because I was so interested in some kind of spirituality, and she told me that I was so confident in Turkey that probably in your first life you you were in Turkey, so you born in Turkey. So probably I have a real feeling, by the way.
Yeah, and Italians, Turkish people, some Greeks are close in tradition and food and some many things.
Georgian as well. We're
Yeah,
as
Georgian.
hot-blooded as Italians, so they say. Thank you.
Okay.
Sorry for interruption. Yeah.
Bye bye.
Thank you for the audience
very
for your
much.
questions. Thank you.
Thank you. Bye bye.